So I have a little splint on that is a static progressive splint for my ring finger PIP joint, and I'm trying to increase extension at the PIP joint. And I just thought by putting it on I could demonstrate some of the principles that we've just talked about. Notice that I am stabilizing proximally my MP joints in flexion. That's to increase the leverage, increase the pull on my stiff PIP joint. I've also am using a finger cuff that is not just the length of my middle phalanx, but is actually the length of my middle phalanx all the way out to my fingertip, so that I get the maximum length of torque. And so the line of pull is going to go over more distal fingers. I'm using a long angled pull, but I'm trying to maintain a 90-degree angle of pull down towards my bone so I don't damage any of the collateral ligaments or articular cartilage of my PIP and DIP joints. And I've really stabilized and made my splint contour really well to my hand over the dorsal knuckles so that it doesn't move at all. This is a static progressive splint, and I can increase the tension as I see fit to get into a maximum tolerable end range. Not a painful range, but a maximum tolerable end range, so that I am applying the idea of low load, prolonged stress over many, many days. And then that idea of TERT is the amount of time that I actually am in the splint in this end range position throughout the day. So low load, prolonged stress over multiple days, the amount of time I'm in the end range position for any given day. And you want to make sure that you're going for the maximum. Please, 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 please tell your patients not to go for painful levels of stress, but to go for the maximum tolerable end range position. Let's move on to critiquing our splint now that it's complete. We want to look at the line of pull. We want to look at our splint to make sure none of the edges are rubbing or digging into our patient's arm. We want to make sure that the patient has the ability to pull on any attachments and control the amount of force. And we want to make sure that our attachments are fairly secure and won't come off with the least a bit of tension. So when we look at this splint, we see that the finger is being pulled into composite flexion towards the distal palmar crease. That's good. Our line of pull is pretty good. And we've allowed enough room below the distal palmar crease, although I might want to allow a little bit more on the ulnar digits, although they're not really included in the splint. And obviously this is not a functional splint. This is a splint that is worn to regain passive joint motion. Our string is wrapped around this extra technique of the bobbin so that we can take up some of this extra string, and the patient can, well, I'm going to let Nancy pull on the...
let me try wrapping it too.
Okay.
This is my first experience with it. So if is the patient going to have to wrap it themselves?
Yes,
or you're wrapping the...
No, the patient is going to have total control.
I'm wrapping very easy, and I can...
Can you add some more tension?
Oh, yes. And
now what happens if that's too tight? Could you loosen the tension a little bit for me?
Let me see.
Just by you don't even have to unwrap the bobbin.
No.
The bobbin winds up and unwinds. I love it.
I love this bobbin thing.
We're now going to begin fabrication of the supination pronation splint. This is a splint for helping someone regain supination or pronation, and this can be made with a dynamic strap or a static progressive splint using a non-elasticized strap. It's really actually two splints in one. We're going to start with our circumferential wrist splint, which we previously made for composite finger flexion. So if you want to repeat that splint design, you can do that, and we're just going to use the base without any finger attachments or outriggers is going to be part of our splint. The second piece, which I'm going to demonstrate its fabrication in a moment, is actually an anterior elbow splint made in forearm flexion, in elbow flexion. Now, as you would know, that the volar or anterior elbow splint would be good for somebody with ulnar nerve problem, and they want to be kept in slight elbow flexion at night so that they don't sleep with their hands in massive flexion. This would be a great splint to make for them. So I'm going to demonstrate how to make this anterior component, but just so you can visualize what the splint is going to look like, we're going to put the anterior elbow piece on, strap it in. It comes over the wrist, and what I will be doing is showing you how to strap either into supination or into pronation, and we hold it there with our strap so that the elbow is flexed and the forearm goes into the direction that we want it to go to regain loss motion.